Hello, welcome to Doctor Talks. This is your host Vivek. Here we chat with the best doctors about diseases and conditions they treat. Our guest today is Dr. Mazda K. Turel. Dr. Mazda is a practicing neurosurgeon at the prestigious Wokhart Hospital, South Mumbai, India. He is also an honorary assistant professor of neurosurgery at the Grant Medical College and Sir J.J. Groups of hospitals. He specializes in the treatment of diseases of the brain and spine and advocates an approach to neurosurgery that is both balanced and proactive. Welcome, Dr. Mazda.
Hi Vivek, it's really nice to chat with you once again.
Doctor, last two episodes were enjoyed and appreciated a lot by our audience, which were about brain tumor and trigeminal neuralgia. In today's episode, we will discuss about a condition called ruptured brain aneurysm. We will understand what is ruptured brain aneurysm, its symptoms, diagnosis, and treatment. Will that be okay, doctor?
Oh, of course, I mean, that's a very interesting topic. The topic of brain tumors and trigeminal neuralgia, which we discussed over the last 2 weeks, I believe was well received by our audience. And I'm sure this will also throw some light into a commonly occurring condition in our in society.
So, to start with, what is a brain aneurysm?
So, a brain aneurysm is basically an outpouching of a artery within the brain. When a blood vessel within the brain becomes weak, it tends to bulge. It grows like a small bulge on it, and it becomes thinner and weaker. And usually it forms at the bifurcation points of the blood vessel. And because of the turbulence of blood flow, and that bubble or blister forming on the blood vessel, there is a chance that it can rupture or burst open. And if that happens, it can cause life threatening intracranial brain hemorrhage. And there are different kinds of aneurysms that we see. The most common kind is a saccular aneurysm, where it's just a very focal bulge on the artery. And then there is a different type of aneurysm called a fusiform aneurysm, which is more, like a generalized bulge of the vessel. It's not a very focal sac. And then you have a dissecting aneurysm where a tear in the inner wall of the artery allows the blood to split the layers of the vessel and pool in between. And that's commonly seen when you have a traumatic injury.
Would you be able to share with us how prevalent aneurysm or ruptured aneurysm is and what is the epidemiological data around it?
In India, we don't have a very strong epidemiological data, but if you look at US statistics, they say that about 30,000 people in the US suffer a brain aneurysm rupture each year. And for statistical purposes, they could say that an aneurysm ruptures every 18 minutes. And that's really a very, very high number. A large population in the US, say about close to 6, 7 million people, are said to be diagnosed with an unruptured aneurysm. That brings it down to about 1 in 50, which is also a scary number considering if we have a large number of viewers, 1 in 50 of them could be harboring an aneurysm. Women are generally more likely than men to have one. They say the ratio is about 3 is to 2, particularly above the age of 55, have a higher risk. And the really sad thing about it is they're fatal in about 50% of cases, whatever you do, even if you treat. And even when you treat them, close to 60% of them suffer some kind of a neurological deficit that's long lasting. I think about 15% of people don't even make it to the hospital. The most common decade, if you would say, would be the fourth, fifth, sixth decade of aneurysm detection and aneurysm rupture. They're known to happen in infants as well. Usually, there is an entity called as familial aneurysms where they are passed down from generation to generation. And in that case, you detect them in children earlier. And about 20% of people harboring one aneurysm may have more than one aneurysm. And really, the outcome and management strategies depend on the size of an aneurysm. When it is about more than 2.5 centimeters, it's referred to as a giant aneurysm. I think the ruptured aneurysm accounts for about 3 to 5% of all strokes. So that, in some sense, gives you an idea of the epidemiology of brain aneurysms and the debilitation it causes. It puts a huge financial burden on people who've recovered from it and are left with a neurological deficit. They require really long-term care and nursing and physiotherapy to recover from a ruptured brain aneurysm.
Coincidentally, a movie with the name Two Hearts is getting released in September 2020. The movie has a plot based on brain aneurysm, and it's kind of very interesting that some awareness about this topic would be spread through the movie.
Yeah, I believe story of a young guy who has a ruptured brain aneurysm and then is declared brain dead and then goes on and donates his organs to about five people. He, I believe, was 19 or 20 years when he passed away, and he donated his organs to about five people, one of whom belongs to the Bacardi rum family, and he received a double lung transplant. And I think the families have been in touch, and it's a true story. Hopefully, it should spread some awareness in these really sad times that we are facing at the moment.
Right. And coming back to the topic, what are the symptoms of brain aneurysm?
See, the thing about aneurysms is that they usually and most often present suddenly. They catch you off guard, and the commonest symptom is a severe headache. Usually, people say that it's the worst headache of their life. It's a sudden onset severe headache, also known as a thunderclap headache. And that's the most common presenting symptom of an aneurysm, because that's when the aneurysm ruptures and it causes a intense surge in blood pressure, and that is what produces the headache. Of course, following that, you can drop down unconscious, or you may still be completely conscious. You may have nausea and vomiting. Depending on the location of the aneurysm, you may have loss of vision or double vision. Usually, once an aneurysm's ruptured, patients don't like sound or light, and they want to be, this is a term we call photophobia. They just want to be in a quiet, dark area. And if you ask them in detail, they're fully awake. They'll tell you that their neck feels stiff. Some of them can even have a seizure at the time of rupture. So, about 90%, 95% of aneurysms symptoms are related to the rupture of the aneurysms. A small percentage of aneurysm symptoms could be just by its sheer size. If it's a large aneurysm and it's not ruptured, it can present with mass effects. So, supposing it's close to the optic nerve, it can present with visual problems. If it's close to the brainstem, it can produce brainstem signs and hemiparesis, or weakness of the arm and leg. So it all really depends on the location of the aneurysm and the size of the aneurysm. But the most common symptom is that of a ruptured aneurysm, and that is sudden onset severe headache, and that's something to be really mindful of. Sharon Stone, I don't know if you've heard of her, the famous Basic Instinct Hollywood actress. She had a ruptured aneurysm, and she had sudden onset severe headache when she was at home and fell to the couch and was thankfully treated in time. And she took really long to get back to her normal self.
Oh, that's an interesting fact. I was not aware of. I had seen the movie, but I was not aware of this fact. What are the causes of aneurysm?
So basically, anything that leads to a weakening of the vessel wall, I believe, can cause an aneurysm. And the most common damage that is done to an artery is by smoking. Obviously, high blood pressure adds to that. If you're heavily into drugs or alcohol, then that's not helpful either. In a large population, there may be a genetic component to it as well. And obviously, with our lifestyle, atherosclerosis is on the rise, and like it affects vessels in the heart, it will also affect blood vessels in the brain. So it's basically a combination of lifestyle habits, atherosclerosis, bad diet, smoking, that would probably cause an aneurysm to form in the first place and then eventually rupture.
And how do you go about diagnosing it?
So the diagnosis is mainly a clinical diagnosis. Anybody who comes to the emergency, or anybody, who comes to the emergency with a sudden onset severe headache, is always suspected to have an aneurysm unless proven otherwise. So the way to detect it is by doing a CAT scan or a CT scan, also known as a computed tomography scan, which is the commonest investigation that's used for brain imaging. And along with that, we do what is called as a CT angio, which tells us exactly now in 3 dimension if there is an aneurysm and what is the size and what is the shape and what is the morphology. And in 90% of cases, this particular investigation, the CT scan with a CT angio, is more than enough to determine whether an aneurysm is present and the exact nature of the aneurysm. In very few patients, you need an actual conventional formal angiogram, which is also called a digital subtraction angiogram, where you stick in a needle in the groin and inject some dye into the blood vessels of the brain and study the circulation in the brain and study the real time anatomy of the aneurysm, and to see whether there is adequate cross flow and if any vessel needs to be sacrificed, etc., can be determined by studying the blood flow in that particular patient. And there could be several variations, and for those reasons an angiogram is extremely useful, though it adds to the invasiveness of the diagnosis, but it's a really good tool that tells us further what needs to be done. And MRI today's day and age is really not very useful for the diagnosis of a ruptured intracranial aneurysm. It may help, in cases of large aneurysms that are detected due to mass effect and non-rupture. If you have a constant headache, you may be able to detect an aneurysm with an MRI, and that will eventually lead to further investigations of a CT angio or of a conventional angiogram that will give you the conventional angiogram still remains the gold standard, but the CT angio is efficient in about 90-95% of cases.
How is treatment planned?
So treatment is really twofold. Basically, you have to treat the patient medically, and eventually, you have to secure the aneurysm. The aim of any kind of aneurysm treatment is preventing re rupture of an aneurysm. Because if the aneurysm re ruptures, and the highest incidence of an aneurysm re rupturing is within the first 2 weeks, and mainly so within the first few days, then the morbidity and the mortality is extremely high. So, all treatment measures are aimed to securing the aneurysm in some sense so that it doesn't bleed again. And initially, the medical management is stabilizing the patient, making sure that the airway, breathing, circulation are okay, making sure that the blood pressure is fine. You want to make sure that the vessels don't go into spasm and cause reduced blood flow to distant areas of the brain, and you give certain drugs for that. So that is really talks about the medical management, but the definitive management is either in the form of surgery or endovascular treatment. Now,
So, doctor, sorry to interrupt. So, what I understand is medication can help reduce pain, but it cannot treat the aneurysm, right?
correct, absolutely. It will make the patient a little comfortable. It will, you give some medication to prevent seizures, you give some medication to reduce the pressure in the brain, you give some medication to reduce the headache. You make sure that the patient doesn't cough, sneeze, and all of those. Any kind of, you give medication to keep the patient calm and composed, so that you prevent a re-rupture till the time you can get to treating it. And ideally, this is in some sense a medical emergency, and treatment of an aneurysm should be secured, within 24 hours of a patient having an hemorrhage, ideally. So if a patient comes to you in the middle of the night, you should do it as the first case the next morning instead of waiting for a couple of cases, unless there are very specific scenarios, whether the general clinical condition and the neurological condition of the patient is extremely poor. Then you may want to wait for the neurological condition to improve a little and then treat. But if a patient's more or less well and talking and is awake and alert and has a ruptured aneurysm, you want to secure it before it re-ruptures, like I said. So there are two options: surgery and endovascular treatment. Surgery involves performing a craniotomy, or opening the head, removing a piece of bone, and then going to the aneurysm, seeing it directly under a microscope, and putting a clip across what we call the neck of the aneurysm, and preserving the normal blood vessel, and putting a clip across the aneurysm prevents it from re-rupturing. This clip is ideally made of titanium, and it comes in varying shapes and sizes depending on the morphology and the structure of the aneurysm, and you may need more than one clip. And they usually vary from 5 millimeters to 15 millimeters. And that procedure involves opening the head, and it's a proper brain surgery, as they call it. And the advantage of this is that the recurrence rates after performing this, the recurrence of an aneurysm is much lower compared to the other treatment that's available, which is endovascular coiling. But the real advantage of the other treatment, which is endovascular coiling, is that it's primarily very minimally invasive. It does not require you to open the head. It's performed using an angiogram in the radiology suite, and the catheter is inserted into an artery in the groin and then passed through the blood vessels to the aneurysm in the brain. And through this catheter, the aneurysm is either packed with coils or glue, or sometimes we put in something called as a flow diverter or a stent, and that does not allow blood to continuously fill within the dome of the aneurysm, and over time the aneurysm will thrombose and collapse. So with this newer technology, the availability of endovascular treatment and newer devices coming up every month, and they're fine tuning what is available to treat these aneurysms, and treatment is becoming more and more endovascularly oriented, and it definitely has a better outcome in certain aneurysms of the brain, like the aneurysms in the posterior circulation. But in the aneurysms that happen in the anterior circulation of the brain, there is still debate whether which is the optimal treatment. For example, middle cerebral artery aneurysms that arise from the middle cerebral artery are primarily still surgically clipped rather than coiled endovascularly, because of the ease of surgical clipping, as well as because of the durability of treatment. If you have someone who's young, you really want to offer that patient surgery in anterior circulation aneurysms, because the recurrence rates are slightly higher with endovascular treatment, even given the development of devices that are taking place. But I'm sure uh, as time passes by and technology evolves, it will come down to what surgical statistics are. And then sometimes some aneurysms may not be amenable to endovascular treatment, and they're pretty large, and we may have to perform a bypass in the brain. And something we call as an external carotid artery to an internal carotid artery bypass, or an internal carotid to an internal carotid artery bypass, wherein which we bypass the aneurysm. It's basically some form of plumbing that takes place in the brain, and you remove that aneurysm from the circulation and allow blood to be restored to that part of the brain through another channel. You may use a graft from the radial artery or from the saphenous vein, or you may use an internal graft itself. So it really depends on the size of the aneurysm, the shape of the aneurysm, the morphology of the aneurysm, and what you're able to do. So the ideal, I think, collaboration is when you have someone who's trained to do both endovascular treatment as well as open surgery, or you can have two people who are exceptionally good at both the options, can sit down together and look at the aneurysm, study it on the CT console, and then decide, in their opinion, what would be the best treatment for the aneurysm. So that's open surgery and endovascular treatment for you. And then sometimes you have to deal with other complications that happen. You may develop hydrocephalus, or this clotted blood obstructs the normal CSF pathways, and that may cause hydrocephalus and raised intracranial pressure. And you may need to put in a drain for some time to release the pressure till the blood gets absorbed by the brain. Or you may need to put a lumbar drain to drain some spinal fluid, keep the brain soft and lax till about a few days, till the hydrocephalus really settles down. In rare occasions, we may even have to put in a shunt, a ventricular peritoneal shunt within the brain. The real problem with aneurysm treatment is not securing the aneurysm, is one part of the treatment, which is we are pretty good at doing it, but we still really haven't understood this entity of vasospasm. A vasospasm, what happens is when blood leaks out into the subarachnoid space, it irritates the arteries. And when it irritates the arteries around the aneurysms, they shrink or they go into spasm. And when they go into spasm, the blood that's supposed to reach the brain doesn't do so. And then the brain, if it's not being supplied with its required amount of blood for an adequate amount of time, can develop an infarct or ischemia. And that's what actually causes the neurological deficit. And this usually happens within 4 to 14 days after the aneurysm rupture. And that's the crucial period. So sometimes we may have to go back again and again to the angiogram suite and inject some drugs that can open up the blood vessel. And we even give oral drugs and intravenous drugs and all of that. And if we can tide through that period where we pass by the time when spasm occurs, then usually patients have a good outcome. So vasospasm happens in about 70% of patients with subarachnoid hemorrhage, and half of these are actually symptomatic for vasospasm. And that symptom may be either a neurological deficit or progressive confusion, drowsiness, restlessness, any of those things. And you need to be very, very mindful of treating this and pick it up in time before an actual infarct sets in. So, and there's a lot of research going on how to prevent vasospasm, and there are a lot of other molecules that are being tried and tested, but really nothing that's actually proven to be 100% reliable to be able to stop it.
So you mean that once a surgery is done, then there is a chance of vasospasm after the surgery during the recovery period, and that's much more creates a critical condition, right?
That's correct, absolutely. That is what is actually more debilitating than the surgery itself.
And otherwise, how is the recovery planned?
So that's it. Usually, first few days, at least a week or so, patient stays in ICU, monitoring the blood pressure, keeping the blood pressure high, and making sure that there's no recurrent hemorrhage. And if a patient recovers well, doesn't have any major neurological deficits, then they go home within 10 days to 2 weeks. If it's an unruptured aneurysm, then the recovery is much faster, and patients can go home within a few days after surgery. because the chance of vasospasm happening is almost negligible in those cases. And then if they don't have a neurological deficit, it's okay, they can go back to work within a month's time. But if they have, even like a mild cognitive deficit, they may require some kind of rehabilitation, either physical rehabilitation, occupational therapy, speech therapy. And really, recovery is really a very individual case to case basis, depending on in what condition is the patient discharged. So it has to be tailored to the patient's clinical and neurological condition, rather than just broadly generalizing what recovery is in these patients.
Now, doctor, some of the causes of aneurysm which you mentioned are more related to the current lifestyle also. Now, so that kind of creates a question in my mind that nowadays we go for preventive health checkup, but is this something which can be discovered during such checkups? Or if not, what I as an individual patient who is now aware about this and this being results in a critical condition immediately, right? How can we detect it early?
So, actually, that's a really great question. If you look at countries where aneurysm incidence is very high, mostly Southeast Asia countries like Japan, and MR angiogram screening of the brain forms part of their routine health checkup. Like, we don't have an MRI screening as part of our routine checkup. It's like a blood test. When you go for a routine checkup, you do a CBC, liver function, kidney function test. In Japan, where the incidence of aneurysm is very high, they do routine MRI and an MR angio to detect an aneurysm. And if they find an unruptured aneurysm, and if it fits into certain criteria of size, etc., they will go ahead and treat it. And that's the only way you can prevent a rupture, by screening with an MR. In our country and our population, and the incidence of aneurysms not being so high, but we really don't know the actual statistics, to be honest, in our country. A screening MRI is the only way to go ahead and see if you have an aneurysm and then treat it electively. That's the only. And but you want one single prevention advice, the greatest advice would be to stop smoking. That would be the greatest thing you can do for your health in general, and for aneurysms in particular.
Yeah, I think, and that's a new insight because in general, a common audience is aware about the risk associated with, say, smoking, which are more towards the cancer and more towards the impact on the lungs. But I think hardly people are aware about the risk of brain aneurysm due to smoking.
Yes, even not only aneurysms, but even any kind of cardiovascular disease, right from heart attacks to strokes, and even peripheral arterial disease. Any kind of disease that involves the blood vessels, smoking is a major, major, major risk factor, and number one on the cards, along with high blood pressure. Because what that does is it damages the vessel wall. And once the vessel wall gets damaged, it becomes weak. And that is what results in a vicious cycle, and eventually a catastrophic event. So, if I were to leave the audience today with one advice, if you're smoking, then stop smoking. That would be my takeaway from this talk.
Great. Your inputs today helped us understand ruptured brain aneurysm and brain aneurysm in general much better. Thank you for sharing your in depth knowledge about brain aneurysm with us.
Thanks a lot, Vivek. It was once again great talking to you, and I hope the audience enjoys this. And we have many more interesting topics coming up to discuss. It's always a pleasure to speak with you. Have a great day.
Dear listeners, please share and spread awareness about ruptured brain aneurysm. And as Dr. Mazda mentioned, one thing which we can do to avoid it is stop smoking. Share this podcast within your community. Cheers till we meet next time.